I am a medical oncologist from Seattle, but I spend a significant amount of time up here in Vancouver on the program that you're going to hear a little bit about, but specifically tonight we're going to hear from Dr. Elliott about maintaining sexual life with prostate cancer. And we're very gratified about how many people wanted to hear this topic. It's really confirming for us that this is a very important issue. Dr. Elliott's credentials are on the slide, but I want to say something about her field, because there are not a lot of physicians or even non-physician nurse clinicians, for example, who really specialize in this area. And I think you guys here in the Vancouver area are very privileged to have somebody such as Dr. Elliott involved in the program. And not only is she involved in the prostate cancer program, but she's also involved in treating men with other disabilities who are having problems with their sexual function. How is this microphone doing?
That's fine.
Okay.
Both of them are on at the moment. If you push the one away. No. Try that.
Okay, well, we'll try that. Okay. I'm going to just actually let Dr. Elliott go ahead and start, but I just want to emphasize how lucky everybody here is to have not only a physician expert in sexual health, but also, Christine, where are you? But also a nurse sexual health clinician who's part of the program. So without further ado, I'm going to let Stacy go ahead and talk about this very important topic.
So thank you very much for coming. I do have a cold, so I hope I don't start coughing. But I think the acoustics are better maybe without the mic. Is anybody that can't hear me? Can you hear me? Okay. So today, anytime we do a lecture by university rules, we have to talk about disclosures. So I have been involved in several continuing medical education projects for family physicians and specialists and consensus panels. I've been on advisory boards for Eli Lilly, who makes the product Cialis, and also Abbott, which is a testosterone product. And I'm trying to mitigate any bias by talking about all the products so that there's not one better than the other. And there's no pharmaceutical involvement in this lecture. So our objectives are, why are there changes after having prostate cancer treatments? What are the current treatments that can help with this sexual satisfaction? And what are some of the future treatments or something that might even prevent having some erectile problems? So whether you're single or you're coupled, sex can still be very important. But for some people, it's not important at all. They're at the time in their life or they're in a time in a relationship where they're done with it. And that's absolutely fine. There's nothing wrong with that. But if you want to maintain a sexual life, either by yourself or with a partner, this is what this lecture is about. So it's part of a holistic and it's a healthy life. These sexual concerns are common and distressing. For men, sexual problems run about the same percentage as the decade. So if you're 60, there's probably 60% of men that have some concerns, usually with their erections, but can be with their libido or orgasm quality or something like that. There's lots of concerns that come from having a medical illness outside of prostate cancer. Diabetes is classic, hypertension. Those type of illnesses can affect your sexual function. And it can be a problem with a medication side effect. So classically antihypertensives, anything that changes your reflexes, opioids, they can all affect your sexual function. But most importantly, this is your sexual life. And it's up to you and your partner who should decide what's important and comfortable. So Christine Zarowski, who's here, and I have brought all these things here. We're not going to talk about them, but we're going to have them here to talk about after. You can take them or leave them. But this lecture is going to be about what happens to you physiologically, and more focus on that than what happens mentally and in relationships, because there's other avenues to look at that. So if you look at this big wheel of sexuality, there's a gender expression, there's a gender identity that's associated, but look at all the factors that are involved in sexuality, especially values and beliefs. All these physical expression, attitudes, pleasures, fantasies, fertility, they're all linked to sexual function. But we're going to focus on the biology today and the sexual function part of it. Because if you can understand what's happening to your sexual function, then you can make informed choices about which way you want to go to help yourself. So why are there changes? These are the changes that we can expect, either to your sexual drive or your libido, to erections, to orgasm or orgasmic quality, ejaculation, which is basically just the fluid coming from the testes and being projected out the end of the penis. That's all ejaculation is. Orgasm is something separate, usually comes at the same time, but they can be separated. And after you've had a radical prostatectomy, you lose that ejaculation, but not the capacity for orgasm. Climacturia is a fancy word saying that when you have an orgasm, there is some leakage of urine. Okay? Penile shortening can sometimes occur. Men complain, especially after surgery, that the penis gets smaller. But the penis also gets smaller if it's not being used. Okay, so there's actually architectural changes, and that's what I'm going to talk about. And is there any pre-existing changes? Is there a bend to the penis? Is there anything going on prior to the surgery or to any treatments? So looking at this picture here, if you cut the penis in half, which isn't a very attractive thought, but if you did, there's two tubes, main tubes, that are really responsible for the strength and the rigidity of the erection. But there's a third tube here that goes down underneath, carries the urethra, which is where your urine's discharged, and it develops into the glands. So there's two tubes and a third one that develops into the glands. And why that's important is that they each have different blood supplies and each have different nerves, although they kind of work together. But take another look. These tubes extend back into the pelvis and they attach to your pubic bone. So when there is an erection, you actually get a mechanical strut. And that's important because some of the erectile aids to assist with erection don't deal with that mechanical strut. And I'll talk about that later. So what happens? Looking at this penis cut again, you've got the two tubes. These are called corpora cavernosa. You've got the spongiosum. And there's this very tough elastic stocking that surrounds those two, or actually the three tubes. There's big vessels on top, and there's big arteries in the middle of each of these. When you get a sexual thought or some sort of sexual arousal, it can be touch or it can be mental thought, what happens is the signal goes down to the nerves, and here's the penis, one of these sections when it's flaccid or soft. Blood goes in and blood flows out. This light pink is your smooth muscle. So smooth muscle is what we have in our lungs and our heart. We can't control it, not like skeletal muscle. And when you get a signal, the smooth muscle relaxes, and this is what happens. There's a certain neurotransmitter that goes up, and it causes smooth muscle relaxation, and the whole tube gets bigger. Each of the tubes get bigger. That elastic stocking stretches, and it pinches off the venous outflow. So just going back, in a flaccid state, the blood goes in and goes out. But when you get an erection, the whole tube is stretched and it pinches off the venous outflow. Very important. So to get an erection, you have to have blood flow in, and you have to have blood flow that's stopped going out. It's called veno-occlusive or venous entrapment. Plus, you have to have nerves that work to signal the whole process. So nitric oxide is the key neurotransmitter. And nitric oxide causes that smooth muscle to relax. So if you have a mental thought, then the smooth muscles are flooded with nitric oxide, and you get the smooth muscle relaxation, and that's how the erection starts. There's also nitric oxide from the lining of your blood vessels. So people that have hypertension, people that smoke, people that have a lot of atherosclerosis and damage to that lining of their blood vessels have less nitric oxide. So before you have any treatment for prostate cancer, you might notice that you have some erectile difficulties. And that's because the nitric oxide sources, or your blood flow in, or the ability for it to be trapped, is somewhat compromised. So these two sources, from the nerves and from the endothelia, are really critical. And the reason I'm going into this is it's because how the pills work. So if you understand this, then you can see why you may or may not work to the pills, like Viagra, Levitra, Cialis. When you get all that blood in there, then you've got oxygen. As soon as you get arterial blood, in comes oxygen. And it's oxygen that preserves the penile tissues. So if you haven't had an erection for 5 years, those penile tissues will have altered. As a matter of fact, the penis will probably feel smaller, okay, because there's less elastic tissue. So if we look at oxygenation in the flaccid state, it's about 20 to 40, whereas in the PO2 and erect state is about 90 to 100. So a lot more oxygen. Okay? So all the treatments for prostate cancer can cause erectile difficulties. So it depends on, are those nerves still intact because they can release neuronal nitric oxide, what your age is, okay? If you've got pre-existing good function, and of course how big your tumor is, okay? Because the bigger the tumor is, the more they have to upset the nerves to get things out. And what are your comorbid conditions, which is another word for what are you like as a healthy person, or are you diabetic, or do you have some other condition that affects the erection to begin with? So your risk factors, your age, smoking, weight, medicines, too much alcohol, if you're diabetic, this is what you walk into surgery with. So when, in a sense, your erectile reserve's already a little bit compromised, and surgery just might knock off that reserve. So you might have more trouble than a younger man that's a marathon runner, for example. So when we look at the treatments of active surveillance, which is basically leaving the penis and the pelvis structures alone, okay, or you go in and you take out the prostate with either an open surgery or robotic surgery. Brachytherapy is putting little seeds into the prostate to try to destroy the tissue, but the prostate still stays within your body. Or external beam radiation, which can occur early or late. And then we have hormone deprivation, and that's usually for more metastatic cancer. I'm not going to talk a lot about ADT today because there's a whole module that you can go to in PCSC in our care program. But you can imagine how important testosterone is. So when you get that stripped from you to lower the testosterone to try to prevent the cells from going, expanding more, then you lose your libido, you're tired, you're fatigued, it's much harder to get an erection, it's much harder to reach orgasm. These are typical sexual side effects of ADT. If we look at erections after you've had surgery, this is some older data. The newer data is not much better, but generally it's between 40 and 80%, regardless of how great the surgery is, because even the best surgeon can't mitigate for some factors that he or she cannot see. Okay? And I'll tell you what those are. So there's a good chance that you might have erection problems after surgery, especially if you have those other factors or you have a larger tumor. Now what's important is here's your spinal cord, okay? Here's your bowel, your bladder, your prostate, and the penis. The nerves that come off the spinal cord wrap around the bowel and the prostate to go into the penis. And a lot of these are called autonomic nerves. So they're very important in sexual function, they're important in bladder function and bowel function. But there's another set of nerves that come low down below here. And those nerves are responsible for sensory and motor function. But when you have your prostate taken out, these nerves should be just fine. Okay, so lots of people ask, well, am I going to lose sensation or is something going to happen? But these nerves remain intact. It's these ones that we're trying to preserve. But you can see by this is a diagram in an anatomy book. But in reality, the nerves are splayed like a spider web. So even the best nerve-sparing technique where you try to lift those nerves away, you can still stretch the nerves. You can cause some what we call neuropraxia, like the little interruption, the signals don't go as well. It's like a statically telephone line. You can actually damage the blood supply around there inadvertently. You cannot see it. It doesn't look like this. It looks like a big bloody mess. So it's very hard for the surgeon to try and do this. So they do the best that they can, and the more experienced surgeons and the higher volume they do, of course, that helps too. Okay? So there's two phases after you've had some radical surgery. The first phase is that these autonomic nerves that we talked about, the sympathetic and parasympathetic, one set of them is kind of hyperactivated, and it makes the penis kind of go smaller, and because those tubes are smaller, you get some venous leak. The second phase is when you don't have erections for a while and you get some smooth muscle loss. So those smooth muscles that are so important to relax, they actually tend to die off if there's no oxygen. So not getting erections for a long period of time causes them to die off. When you do that, it causes more fibrosis or more collagen, not elastic fibers, but the collagen. And that makes the penis sort of more crinkly, right? It doesn't expand as well. It's starting to get more fibrotic. And that causes it to shorten, and it causes it to have more difficulty to expand later. So what we do in penile rehab is try to get those tissues more expanded. There's something called Peyronie's, which is a bend in the penis. That stocking that goes around can have a scar on it, and the penis will bend around that scar. And the incidence of Peyronie's after having a radical, for some reason, increases. So some men, they have good erection function, they have surgery, and after it takes a while to get their erection function back, and they notice that the penis bends. It's not because of the surgery per se, it just seems to be a higher incidence after this whole pelvic trauma. Okay? So further, the less erections you get, the less oxygen you get, and the whole process starts again. So there's more veno-occlusive dysfunction. So the cavernous nerves gets traumatized, then the nitric oxide goes down. If the nerves are hurt, there's less nitric oxide, you get lack of oxygen. And then you get all these fancy factors that come along and invade the penile tissues, and it causes the smooth muscles to atrophy or get smaller and die. The elastin fibers go down, the collagen starts to deposit. Then we get some penile contraction and shortening, and finally we get this veno-occlusive dysfunction, because if the two tubes can't expand, then you get a venous leak. So venous leak is very common. So after a radical prostatectomy, there's venous problems. You can have arterial problems because you could hurt the arteries in it. And then you can have this neurogenic problem or nerve problem. Okay? So more hypoxia. What about if you have the seeds or if you have radiation? So the nerves and vessels regulating the erection are also damaged, but not right away. So the effects of the radiation occurs over months and even years. So initially, you might have other problems, some urinary irritation or bowel irritation, but you might have a good erection for a while, but over time, that erection will start to become a problem because the nerves and the vessels are affected. And if you look at how many men have obtained potency after post-brachytherapy, you can see at the beginning it's pretty good, and then as the years go on, less and less. And that's because of this process that happens. It's same with external beam. Better at the beginning, and then as the years go on, you have less and less potency. Now I want to tell you, when you look at studies, the way that they measure somebody's erection on scales, or whether they're potent or not, whether they can have intercourse or not, their studies are all over the map. So it's very hard to compare studies and get true rates of erectile problems. So take everything with a little bit of grain of salt. And surprisingly, I had a young man who was 49 who had a radical prostatectomy, who then had external beam radiation, and after about 5 years, and he was using medication in the meantime to keep the penis active, his spontaneous erection started to come back. And I've hardly ever heard of that. Okay? So there are these outliers that for some reason do well. And there are people that have a perfect surgery and really good care and exercise and do everything they can, and they still have problems. So when we go into this area, we have to expect that things are not going to be really nice and clear and tight. And the best you can do is to take care of your health and try to take care of your penile health to maximize what you can have. What about some of the other sexual issues? Well, obviously some people have trouble with their libido, their sexual drive. And it's a very complicated process. It has to do with your biopsychosocial way of approach of life. So yes, some biology might be changed. Yes, you might have a little bit of depression. Maybe you've got a post-op infection. Maybe you've had a fight with your partner. All these things affect how your willingness to be sexual. So it is probably one of the most common things that we see after any treatment for prostate cancer is a drop in libido. You don't feel like being so sexual, especially if you have some urinary issues or urinary incontinence. So it's very complicated. And it's related to your quality of your sexual function, your urinary continence, and your relationship issues, and other things, other predisposing things that you had before. So depression can be a major factor in low libido. What about the penile shortening? So if you look at studies, they say there's about a 1 centimeter shortening after you've had surgery. Okay? And this can be expected up to about 12 months. But another study came along and said, well, that's fine, but if you carried on with people that kept trying to get erections, over a year or 2 years later, the penile length seemed to be okay. So we don't have good studies about this, but the complaint that the penis is shorter is very, very common. Okay? So the best thing you can do is try to give it erections so that it keeps those tissues elastic. And a vacuum device, we have one here, is something that some people use, which is a mechanical device to draw blood into the penis to try to keep that penile length as long as it can be, and there is some evidence that it works. What about the lack of ejaculate? If you've had surgery, then these tubes that go up here in the seminal vesicles, they get taken away. So the prostate, the seminal vesicles, they produce fluid. And because the tubes are cut here, then there's no sperm either. So there's a loss of ejaculate. And it's not usually a big issue for some people unless they want to have a child, in which case you should be sure to store some of that sperm before you undergo this. But for some men, orgasm is associated with the feeling of ejaculatory fluid going through these tubes. And so for some men, after any prostate cancer treatment and there's no ejaculate, they feel the orgasm is different. Other men don't feel a thing, any change. Okay? What about orgasmic concerns? After a radical prostatectomy, there's about a third of men that say they have pain. Usually at orgasm, there's a sort of a contractile pain. It tends to get better in 3 to 6 months. Some patients, it carries on. It's probably spasm of the either the urinary sphincter that's been sewn, or it's a spasm of the pelvic floor. It's very hard to treat, but we have some ideas what to do. A third of patients will say that their orgasmic quality has changed, that it's kind of worse, it's shorter, it's less intense. And other people say, actually, mine got better. And this is a true story. I had a patient that asked me whether or not when they took out the male stuff, if they put some female stuff back in, because his orgasm now goes all the way up his back like his wife's. And I thought that was really cool. So what happens for him is that the anatomy did change, but it gave him a different visceral feeling of orgasm, which was beneficial to him. We don't usually hear that. We usually hear that it's either the same, about a third, or there's some diminution, or there's a little bit of pain. But overall, there should still be orgasmic ability, and that's very important. The surgery doesn't take away your ability to experience pleasure. And there's also partner issues. So this is a picture of a female, but there could be a male partner. And it does affect partners. And I really want to emphasize this. We could have a whole lecture on the relationship issues and how to communicate and all these things. which could take another hour. But I want to emphasize that the partner that's involved with what sort of erectile enhancement you're going to use, if there's a partner involved and in the decision making, you're more likely to go forward successfully. Partners that have had a good sexual life prior to surgery or any treatments are more likely to be successful in their sexual life after. So it's just like your health. If you have a health issue prior to surgery, it's thereafter. If you have a relationship issue, it's thereafter. Okay? So you need to recognize that you might need some help around this area, and that's okay. So Christine Zarowski, who's a sexual health clinician here, she has a module, an education session for men that are newly diagnosed with prostate cancer about managing the impact of all these cancer treatments. So I encourage you, if you're in that category, to go. And she and another clinician have an intimacy workshop. And if you've been part of the PCSC program and seen one of the sexual health clinicians, then you can attend that also. And that's very important because that's the more touchy-feely, more intimate stuff that's very important to both men and women. And we don't always have time in a medical clinic to address this, but it is as important, if not more important, than what pill you're going to take. So what are the current treatments now to help with this? First of all, what can you do to help yourself? You want to make sure that your diet is healthy. We've had a lecture on food because weight loss, if you're overweight, can be very helpful. It's not going to bring your erection back, but what is it going to do? It's going to prevent secondary causes of sexual problems, and it's just healthier for you. Don't forget the lining of your blood vessels is giving you some nitric oxide, so you want to do whatever you can not to hurt that lining. So you need to stop smoking. By the way, you want to stop smoking before you have any therapy because your chances of healing are way less if you're a smoker. So you want to get rid of that. Okay? Exercise is really critical. And if you want to be in the best health you can before and the best health after, barring any sort of catheter you might have or something. So you can ask your surgeon about that. So penile rehabilitation then is any form of rehabilitation to get the penis back to what it was. And you want to reverse that lack of oxygen, which is going to happen when the nerves aren't working as fast as you can. The reason you want to do that is you want to increase nitric oxide because that pushes up the amount of oxygen there is. So how do we increase nitric oxide? One of the ways is to physically touch the penis, even if it's massage, even if it's a vacuum device. It doesn't have to be an erection. But when there's physical touch, you get a little bit of nitric oxide release. So the tissues are exposed to that, which is very important. When you release the nitric oxide and the oxygen goes up, all those nasty neurotransmitters and things that affected elastin and collagen, they reverse. And the good guys come out and they promote elastin and they decrease the fibrinogen. So that helps with the smooth muscle health. So bottom line is erections help erections, and that's what penile rehab is about. Even if you don't use them sexually, try to get erections 3-4 times a week or even once a week so that those tissues get that oxygen exposure. And the options we have to do that is to enhance that using pills, Viagra, Levitra, Cialis, or Staxin, or to create erections with mechanical devices or putting injections in the penis that cause smooth muscle relaxation. Or the very last resort would be to put a surgical implant that takes the place of those two tubes. But once you've done that, you've destroyed the tubes, and you can't use other ways of doing it. You can't use injections or pills. Okay. What are the PD5 inhibitors? That's a fancy word for phosphodiesterase 5 inhibitors. It's a class of drugs that makes that nitric oxide hang around longer. So all they do is enhance erections. They actually inhibit an enzyme, and so they're not like a drug. Okay, so it's a reversible effect. You don't become tolerant to it. So if you take these pills at the time that you take them, the nitric oxide that you produce by sexual arousal and by physical touch hangs around longer. So that means your erection is better and it lasts longer. So Viagra, Levitra, and Staxin They act best about 1 to 4 hours after you take them. And they can be affected by a very high-fat meal. So if you do go to McDonald's and you eat something really high-fat and you take a Viagra, it's not going to work in 1 hour. It might work 6 hours later when you're passed out. And then you're going to tell your doctor it doesn't work, okay? So really be careful how you take it. If you're going to take Viagra and go out for a nice dinner, you might as well take it prior to your dinner. Because it does last beyond 4 hours. Some men say they wake up with a better erection with it. The longer acting one, these pills, they act between 24, this is Cialis, 24 and 36 hours. So if you took a pill on Friday and your partner had a headache Friday night, guess what? You're going to bug her on Saturday because it still lasts. Okay? And that's the effect of the Cialis. So it's very good. The other thing with Cialis, it's a little more spontaneous. You don't have to plan so much. But some people don't like this because they don't want the pill hanging around that long. If you are on nitrates for your heart, which is for angina, you cannot take the PDE5 inhibitors. So that's one of the contraindications to it. The other thing about Cialis is it's not affected by food. So it doesn't matter what kind of meal you eat. So all the PDE5 inhibitors are not affected by alcohol. That's a myth that's out there that you can't have a glass of wine and take a PDE5 inhibitor. But if you drink too much, then all your sexual function goes down. So you don't want to have too much wine. Okay? So what's the evidence that PDE5 inhibitors help with getting your erection back after prostate cancer treatments? Remember, it only works through intact nerves. It enhances the erection. It doesn't create one. So you have to have some nerves going down to the penis for this to work. So initially, PDE5 inhibitors may not work at all for 3 months, 6 months, even 12 months. But if you have some nerve regrowth, they might start to work at 18 months or 24 months or 48 months. So if you were on a more invasive method like injections, always challenge yourself with a PDE5 inhibitor another 6 months out to see if there's more nerve growth and maybe they will work. So in the animal models, if we give people, rats, PDE5 inhibitors the minute that their nerve is cut, and we watch what happens compared to rats that don't get PDE5 inhibitors, and then we sacrifice the rats and we look at all the tissues, there is more smooth muscle, there is more nerve conduction properties, there is more endothelial nitric oxide. So we thought, wow, this is going to be great, because in the rat studies, if you took these PDE5 earlies, it seemed to preserve some of these tissue changes that we were going to have to be a problem. It seemed to help with all smooth muscle, arterial, and nerve regeneration. But we don't have clear evidence of that in big human trials. They're very wishy-washy. So even though it looks good from a biological basic science perspective, we haven't proven it in humans. So in the Department of Urology, there's a big fight. Those people that say, I don't care, I'd rather take it than not, and those people that say, we don't have the proof and it's expensive, why waste your money? And typically, most people in prostate cancer centers are using PDE5 inhibitors as part of penile rehabilitation, on the chance that there might be some preservation of the tissue by using this. Okay? Even though the evidence isn't strong. The downside is it's very expensive. And unless you could afford to do this, you won't necessarily get erections from it, but there might be something happening at a cellular or a neuronal level that will help with the spontaneous erections. So a recent meta-analysis said, not worth it, don't bother wasting your money, but it's still a very common practice. Okay? And there are studies that show that it does improve, and the bigger studies show that, well, maybe it doesn't. There's studies that show that if you have sexual arousal and sexual touch, even with masturbating with a flaccid penis, that is a better chance of getting an erection down the road than if you didn't touch it at all. And that means it's to do with oxygen, right? So the word is not out on that, but in Vancouver, we tend to use PDE5 inhibitors as part of our penile rehabilitation. What about a more mechanical way? If we take a vacuum device and we place it on the penis, we create a vacuum, you actually draw blood into the penis. The problem with this is that it doesn't hit those struts, because this is where the blood is drawn in, but it doesn't give an erection all the way back into the struts like the PDE5 inhibitors do. So when you put the band on to contain the erection, it's going to swivel on its base a bit. Does that bother some people? Yes. Does it bother most men? No. Okay, they manage to hold the penis and they can have intercourse with it. It's not a big deal for most men. But it is something to mention. For penile rehab, you're taking in arterial blood, but also venous blood, which has less oxygen. So this method doesn't give you the same arterial or oxygen ability as something like an injection, which we'll talk about in a minute. But it's still good. It's still giving you an erection. It's still be maintaining penile length. And you can use it for sexual purposes if you want. So a lot of people will get a vacuum device just for penile rehab and maybe never use it for sexual purposes. But you have the option. And we have a person that you can see here to help go through this device. And actually, it's a one-on-one appointment, so you can see what it's like and whether it works for you. It does take a few weeks to start working. Because when you first use a vacuum device and you haven't had an erection for a while, it feels like somebody's just pulling on the penis and nothing's happening. But after 2 or 3 weeks of daily use, you'll finally get a full erection. So you need to have some patience with it. So because there's venous and arterial blood, you still can create an erection. The oxygenation overall is still improved. There's a study that had about 110 men, and they had daily vacuum device for 9 months compared to no treatment. So one group did it for 9 months every day, the other group didn't. 80% were able to have intercourse with a vacuum device, but only 17% could without the vacuum device. In other words, the amount of men that had an improved spontaneous erection without using vacuum devices down the road were better with the guys that were using the vacuum device than the ones that weren't. So the recovery rate of spontaneous erections was better with the vacuum device. And again, it may help reduce penile shortening. What about injections? So injections everybody cringes at, but this is a small needle, and we have excellent teaching here. And one of the downsides of injections, why 50% of men drop out of doing injections, I really think is because they haven't been taught properly, they haven't been followed, and they haven't been encouraged to increase the dose at a very conservative rate. So injections put a neurotransmitter directly into the penis that causes smooth muscle relaxation, even if your head's not into it. So that means it's kind of weird sometimes because you have this erection and you might not have any sexual drive. But you have an erection. Okay? And so sometimes there's some good feedback with that. The downside of injection is if you inject too much, the smooth muscle relaxation continues and you have a prolonged erection. And that means you have to go to emergency and get a shot of something else to reverse the smooth muscle relaxation. We don't want to go there. Okay? And after you've had a nerve damage, you're very sensitive to this medication. And there's different types of medication we use. Some people get a little penile aching. If we do that, we switch to something else. So this is an extremely useful method. It goes all the way into the back, so your struts are full. It's a natural erection, but we have to be careful with it. So that's why the instruction is important, and we can do it here. And so as far as I know, we haven't had anybody with prolonged erection. No? Okay. So we have good success. Now, you learn to do this by yourself. Chris and I are not on pagers, okay? So you learn to inject this by yourself, and you learn to use it at home in your own privacy, okay? So it's very good. So what's the evidence that if you start doing injections early after prostate cancer treatment that your spontaneous erection recovery rate will be faster? Well, there is some evidence to that. And if you did injections 3 times a week, 67 or 2/3 of the people had spontaneous erections where only 1/5 of them didn't when they did use injection. Why is this? It's because we're reversing that hypoxia process, right? We're creating an erection full of arterial blood, so the oxygen levels are really good with injections. Okay? So There's another thing, the same drug that we inject, we can actually put in a little pellet inside the urethra. It's less invasive than a needle, but I have to tell you, after prostate cancer treatments, it's not that effective. And the reason is, you have to get, remember I said this tube along here and the glands is different than these two tubes? When you're putting it in the glands, it has to get to the two big tubes, and that needs retrograde venous flow, and some people just don't have that. So it's not as effective and it's quite expensive. So we tend not to use it here, although some people do. They put a band on the penis to keep the medication in here and help. What about future treatments? What's coming down the pike? Is there anything that could just abort this whole process? Right now in the U.S., there's another PDE5 inhibitor called Avanafil, but it's still the same drug class as Viagra, Levitra, Cialis, and stuff. It's the same thing. They have, every drug has their big claims to fame. We don't have any data about Avanafil working in prostate cancer better than anybody else. So it's just out. But if you hear about this in the future, just remember it's like the other pills. Now the other pills, some men work better to Viagra, some work better to Levitra, some better to Cialis. Some people have less side effects, headaches, tummy upset. You have to try them to see what works for you. Because if you have trouble with one, you may not have a trouble with the other. So same with Avanafil. We don't know if you're going to have side effects to this or not. The only thing you could do is try. The same drug that we inject, the same drug that we put in the urethra, is going to come out in a cream form that you drip around the glands, okay? And it's called Viterra. So it's prostaglandin is the same thing we inject that is in Muse and in Viterra. This has been approved in Canada, but there is no Viterra available right now. And there actually isn't in the States either. So I think there's some manufacturing stuff going on, but eventually you might hear about this new penile cream. And it's about this Viterra. Again, you're putting it around the glands. So it may not work as well as putting it directly into the two main tubes. There's a sural nerve so in the operation, when they've cut some nerves, they try to take a nerve from somewhere else and patch it on there so that the transmission stays great. Okay? So sural nerve grafting sort of fell out of favor because the actual potency rates after were not that great. There was also a CAVR where during surgery they tested the nerves to see if they were still intact. Okay? It was a way of mapping the nerves during surgery. So those two things, even though they're great ideas, didn't seem to make a huge difference. The future that we're looking at is there are some penile extenders now that they look kind of ridiculous, but they stretch the penis and they hold it at a certain length. And if you take any skin or any tissue and you put pressure on it, the body tries to fill in that void. So if you stretch the penile tissue, you have less retraction and you have less loss of smooth muscle and other structures because there's a void that the body's trying to fill in. So penile extenders are sometimes used. We use them, they're definitely used after Peyronie's. You remember the curvature? After surgery for Peyronie's, they use these extenders to keep the retraction and the new tissues they put in nice and stretched. So this is very early evidence that maybe penile extenders might help with the penile shortening after radical prostatectomy. We've also looked at stem cells. Everybody talks about stem cells and how wonderful they are because they're a cell that can turn into anything. But in reality, when you put in a stem cell into the penile, rat penises had looked at this, the stem cells think, well, maybe they'll turn into smooth muscle and nerve cells and all the tissues that are damaged will be preserved. But what they do is they go, wow, the nerves are damaged and all the stem cells go into the big ganglia into the pelvis where the nerves originate from, and then they eventually go back to the bone marrow, which is kind of where their home is. So they didn't stay in the penis. Okay? So that's unfortunate. This is all rat studies. But maybe in the future there'll be some help for small parts of the penis compared to trying to keep the whole erection and the whole mechanical situation going. They're also injecting through viruses and things to put actual medication into the penis that causes proteins to be made that make your tissues survive. Okay? So if you're losing some sort of tissue through damage, these proteins will help keep those tissues going. So this is called gene therapy, and it's very, very early on, and we don't have anything that's available commercially in terms of gene therapy. But it may be very helpful to prevent erectile dysfunction. For example, men who have diabetes, type 1 diabetes, young men start getting erectile problems because of all the complications from the diabetes. And they're looking at gene therapy to inject into the penis so that that young man never has erection problems, because the gene therapy's helping with all the proteins in the penis. The other one is using erythropoietin, which is EPOS is a type of medication that increases the oxygen. So if we're looking at hypoxia in the penile tissues, can we inject or can we give some sort of compression where there's more oxygen to the penile tissues? That hasn't proven out that great, but it's being looked at right now. So a lot of this stuff is still in animal models. But what we do have, it may come to Vancouver, is something called low-frequency shockwave therapy. When you have a kidney stone, they use shockwave therapies to blast that stone apart. But low frequency, not high frequency, but low frequency shockwave therapy looks like it might have a little help in increasing blood, the development of blood vessels. Okay? So there's a machine that you can put on the penis and do treatments on the shaft and on those struts that we talked about that helps create new vessels. The problem after prostate cancer, even though there could be some vascular damage, is it's not really about vessels, it's about nerves. And this doesn't help with nerves. Okay, so it helps with growth of new vessels, but it doesn't assist with nerve growth. So it's not programmed for using in post-radical prostatectomy. The reason I'm telling you about this is I think it's going to get more popular, and there's going to be some clinics that don't do proper assessments, and you're going to pay a lot of money for something that may not work. So this is not for the prostate cancer patient. It's probably for the diabetic patient that has trouble with the blood vessels. Okay? So it's growth of new vessels, not nerves. And when I was at a conference in Spain last week, they presented a paper about using vibration after radical prostatectomy. Why would you use penile vibration? Penile vibration may cause or create erections in some men, but after you've had nerve treatments, why would vibration work? So I've worked in spinal cord injury for a long time, and we use very high-powered vibrators to get sperm from men. So because they can't ejaculate after having a spinal cord injury, a lot of men can't ejaculate, so they can't be biological fathers. And we use very high-powered vibrators to get an ejaculate, and then we put it in the uterus, or we use some other artificial insemination method to get the wife pregnant. So we've had about 100 babies this way, which is great. So with the vibrator, we actually place it on the penis, and then we get our baby, and everybody's happy. So here's a guy with a spinal cord injury, high spinal cord injury. He's had all these babies. So vibration works to trigger that ejaculation reflex. But there was a study done by a couple urologists that looked at vibration helping women with stress incontinence using a vibrator, because it's a reflex arc, okay? Reflex arc with a vibrator, to strengthen their bladder control and their pelvic floor so they didn't have so much urinary incontinence. And it kind of worked. And I'm sure it was very pleasurable at the same time. But they took that, then they said, well, can we apply that to men after a radical prostatectomy? The inference is that you put a vibrator here, it goes into the spinal cord, and you get a reflex back. So they looked at men that had some nerve sparing. So if you've lost both your nerves, this isn't going to work. But if there's some nerve reflex left, the vibrator can assist with that. And I have to tell you, this isn't a little buzzy vibrator that you get at a sex shop. This is a big vibrator, amplitude of 2.5, hertz of about 100. So it can actually be almost uncomfortable. It's how strong the vibration has to be in order to trigger the actual benefit of coming back to cause reflux on the pelvic floor. So this is the spinal cord one we use, the Ferticare. This is the one they did the study on. And there's another one here, Vibrec, that I can show you here. They're starting to advertise. This particular guy is a urologist in the States, drives everybody crazy, but he might have a good idea that if he can use the Vibrec to try to do penile rehabilitation, get that nitric oxide release through vibration if you have some nerve sparing left. So where do we go from here? You need to decide what is the priority sexual activity holds for you and your partner. You need to come to some sort of adaptation or agreement that this is what you want to do with your sexual life. If you're single, there's a lot of men that want to have a better erection. It makes them feel better. And it's kind of like a bad hair day for women. When men don't have an erection, it's part of their identity. It's part of who they are. So they want to see an erection. Some men just want to see it, and they may never even use that erection enhancement aid. But I think Chris and I understand through all these years of talking to men, erections are important for them. And I think that's why you're here. And so is the other components of sexual function, which is your libido and your orgasm and ejaculatory function. It's also important. You don't want to have pain when you have sex. You don't want to be leaking urine when you're having sex. It doesn't make you feel good. So that's what we try to help you with in our sexual health module, is to look at the whole picture. And if you have other issues, arthritis, stroke, diabetes, we try to help you with that too, because that is part of who you are as a sexual person. So again, the rest of the sexual part, including weight changes. Sometimes men on androgen deprivation therapy, they get a tummy or they put on weight because they lose muscle. And that doesn't make them feel very good about their self-image, or their sexual self-image. So we also try to deal with that. So we acknowledge that all these things feed into sexuality. Try to be as proactive with your health, and that means penile health too. So the penile rehab piece, I think, is really important. And even if you are 5 years out or 10 years out, that doesn't mean that we can't start helping you now along those lines. The future certainly holds some promise to prevent erectile dysfunction. And there's a book that says, women are from Venus and men are from Mars, and I really disagree with it, because I don't think you're that different. I think your main reason why you want to be sexual is to be intimate. And so if having an erection helps that, go for it. If not having an erection and having non-penetrative activities is okay with you, go for it. It's fine. The goal is that you're close. So some of these gadgets that we have here, people go, ooh, I don't want to do that. And other people say it's kind of fun, and it makes us close. So it's all individual, and it's all up to you. So I'm going to take some questions, but and Chris is going to come down with me. But please ask me and give me some feedback, and I hope you enjoyed this talk. So I think your question is, can we use these penile rehab things together? And is it safe to do that? Anything that's mechanical is safe to use with anything that's a medication. Okay, so you can use a vacuum device with anything. When you take low-dose PD-5 inhibitors as part of a penile rehab, like daily Cialis or Viagra every 3 nights a week or something like that, and then you want to use an injection, if you're not getting any erection through those PD-5 inhibitors, then it's safe to use the injection. If you start getting an erection to the PD-5 inhibitors, it's probably not a good idea until you see Chris or I to combine them.
Continue with the. I actually have a separate question about the injections. Are they covered through medical services?
Yeah, that's a good question. So the PD-5 inhibitors, unless you have a really good plan, is not covered. Is Blue Cross covered?
No, and there's just actually a few insurance companies that might. One of the things that we actually try to do is provide a justification letter. with the urologists that we have. And I think the more that different insurance plans get this letter about supporting low-dose PD-5 inhibitors for penile rehabilitation, because it helps with so many other aspects of quality of life, I think we are going to see, hopefully it's going to be covered soon in the future.
I was actually referring to the injection.
Yeah, so
Okay.
pills are not typically covered. Vacuum device is not typically covered, but we can write a letter. But injections after prostate cancer, we can write what's called a special authority, and most of the time it is covered. Okay. Yeah. Yes.
I'm curious about the link of the orgasm with the erection. So the nerve, nerve sparing. What are the roots that are affected or may be affected to actually achieve orgasm without necessarily having an erection? Is there a relationship? How does that work?
So orgasm, we don't know the neurology of orgasm. We know ejaculation, we know erection, but orgasm is sort of, we think it's partly a reflex, okay, which is kind of what we did in the vibration, but there's other components to orgasm. For example, when women have an orgasm, their uterus contracts. For some women, when they take that uterus out, they don't feel any difference to their orgasm. But other women that had a sense of that contraction, it was part of their orgasmic quality. So when they get a hysterectomy, their orgasm is different. So there's something going on around the organs, and there's something going on in how your brain interprets it. In my work with spinal cord injury, they don't feel anything, right, from here down. But over time, by massaging their ears or rubbing other areas, breasts that they can feel, they learn to have an orgasm not from the genitals. So those non-genital orgasms are very important. It's part of tantric sex and all that stuff. So after you've had changes to your anatomy, it might feel different, but if you pay attention to signals in your body, eventually you sculpt a different type of orgasm. Does that make sense? So even men that have lost their penis in an accident, or they're transgender and they have surgery, they still can have an orgasm. But it's very helpful to have that nerve at the front intact, which is the one that gives you sensation. Okay? So if you actually get rid of that nerve, orgasm is very hard. But you're not doing that with surgery.
And those are the nerves that come underneath.
That's the pudendal. Yeah, yeah.
One other point I want to add to that, when you think about your body, your whole body is receptive to pain. If there's injury or a certain trauma that's put to any part of the body, your body can receive pain. Your body is also receptive to pleasure. So a lot of times when people learn how to be sexual with each other, they might establish a pattern of how to enjoy pleasure. So a lot of times when you've gone through prostate cancer treatments, it actually creates what we call an opportunity to re-explore your body, how it can receive pleasure. We've had men that have become multi-orgasmic, like Dr. Elliott was mentioning, is that the experience of orgasm can be better. So it's very, very important to keep open-minded and to, like Dr. Elliott says, be aware of how your body is responding to the different types of stimulation that you're exposing it to.
And that applies to partners too.
Yes.
I don't know if we have that in Canada. Do we,
Well,
Tia? Yeah.
No, unfortunately, we have way too many protons. It's proton radiation therapy. In the United States, we have way too many of those. There is no evidence that proton therapy is actually superior to the standard photon therapy, which you do have here in Canada. And I would not pick proton therapy for that reason, because for proton therapy to work, it still has to kill cells. And that's being said, it's going to also affect the nerves and blood vessels that Dr. Elliott mentioned, that, after radiation, whether it's proton, photon, or sometimes brachytherapy, in 5 years' time, your erectile dysfunction is going to be the same as whether you had surgery.
Okay. So my next question then related to the same thing, is that I'm battling with the time thing, and nobody can answer that, especially my doctor won't answer it. He doesn't really know, but is if I was told that if I was 60, they probably wouldn't even treat my cancer. But I'm 48 or 49, and because of that, they want to treat it. So that means I have some time, but I don't know how much. And is there something right around the corner that, of course, nobody can talk about yet, that may be mainstream in 5 years or 3 years, that I would have to go through this? Like
Well, I would suggest that we have a conversation offline, because that's kind of a little bit off this topic, and I'm happy to talk to you about that afterwards. So for right now, we'll kind of stick with these questions, if that's okay.
Just going to take that one. Yeah.
On the injection, on the medicine that you inject, does that come in various strengths?
Yes.
Because what I have found that initially it worked, but then it got weaker and weaker. I had a weaker response to it.
So the injections, there's 3 drugs that we use. The main one is prostaglandin. Usually comes in 20 microgram per mil. You can get double that strength, but typically it's 20 microgram per mil. The reason we like prostaglandin is because it causes less scarring over time, okay? Less chance of prolonged erection over time. But we often combine it with a phentolamine, papaverine phentolamine, okay? And we had papaverine phentolamine 25 years ago, okay? But we just got prostaglandin 15 years ago. So in our clinic, we try to use prostaglandin unless it causes some aching. Sometimes it causes aching after nerve surgery. So in that case, we just use the papaverine phentolamine. But there's a combination of all 3 called triple P or trimix. So the strength of all of those are different. Okay? But I think the main reason why the injection starts to not work so well is because what's ever causing your erectile dysfunction is getting worse. So if you take a man that responds to a little bit when he's 50, he'll probably need more when he's 80, just because he has less blood flow in the penis to begin with. So aging changes will make your dose go up. Not so much that there's something wrong with the medication, but that your natural changes to erection are getting worse, so you need a higher dose.
So a secondary question. My own doctor has difficulty in assessing what the strength should be.
So I think the key is it's not so much the strength. I mean, strength is important, but what is the volume? So the best thing to do is start with a very, very low volume. That may hardly work. And then we have a sheet that tells you how to increase so that you don't get in the danger zone. So it's okay to use 0.1, 0.5, a whole cc. It doesn't matter how much you use as long as you get the result. But we start very slowly and work up slowly, okay? And that's why we follow you to make sure that you get the result that you need. So sometimes the medication, if it's left out on the table, it's supposed to be in the fridge. If it's left out overnight and it hits room temperature, it'll lose some of its potency. The expiry date, got to watch that, it'll lose potency. And different pharmacies have different mixtures. So, it's hard, right?
Now, where would one, I mean, my doctor doesn't seem to be able to handle this, so who would one see about?
Well, we have Christine, who's part of the sexual health module, and that's exactly what we'll help you with. Yeah, for sure.
The other thing just to remember too is how you're landmarking on your penis, because sometimes it's where you're injecting as well.
I've already carried that.
Okay, good. Okay.
We had a question here. Yeah.
When you hear injections and needles, it's somewhat frightening.
Yes.
How big is this device and how easy is it to use?
I use the comparison that some men who have bladder problems have to learn to catheterize. I think that's way worse than trying to deal with a little tiny insulin needle. It's 8 millimeters long and it's super, super thin. It's the idea. So when we teach you this, you see a video, there's a demonstration, and then we actually get you to do an injection in the clinic. And once you've done that, you're kind of home free. It feels like a little mosquito thing. if you're doing it properly. Okay? Some people get a lot of pain with it, and it's usually incorrect technique. So then we bring you back, and we encourage you to keep trying, and we show you little tricks to avoid that. Some people that have a real needle phobia use a injection pen, but it makes a big bang. So I'm more scared of that than anything. Yeah. Go ahead.
Daily dose Cialis, can you speak a bit about the dosage? Should we increase the dosage or?
So the daily Cialis is 5 milligrams, and it's about $125 a month. So it's very expensive. And the best use of that is when, if you do get some reaction to it, and you do get an erection to it, so you don't have an erection 24/7, right? You only get an erection to sexual arousal. That's probably your best sort of bang for your buck is when you getting erections with it. In the penile rehab part of it, again, we don't have the solid evidence, but you're continually exposed. So when you use daily Cialis, your actual blood level is not 5, it's about 8. So you're continually exposed in that. The other penile rehab PD5 regimens are, Monday, Wednesday, Friday, okay, of something that's not so long acting. So we don't have the studies saying which one is better, okay?
What about taking larger doses?
So I don't see the point in taking larger doses unless you want it to get for sexual purposes.
So you could be on a daily routine, but on a sexual basis, you take more.
If you need it, yeah. So quite a few men will be on daily Cialis. Their morning erections are a bit fuller. Their spontaneous erections, they drive by a Victoria's Secret ad and they get a little erection. And then, when they want to be sexual with a partner, they take a Viagra on top of it. And you can do that as long as you don't have the side effects and there's no contraindications. But again, that's expensive, right? So some people say, if I can get an erection to Viagra or Levitra, I'll just take the Levitra or Viagra. I won't take the daily, right? But the daily is very helpful psychologically because it feels like the other thing with the penile sort of shrinkage, it tends to push the penis out a bit because you have more congestion in the pelvis. So a lot of men like that sort of feeling that they feel like they're reattached and it feels good. Yeah. Yes.
I want to say, first of all, Dr. Elliott, thank you so much for this because I swear I would love to have had this 6-8 months ago. My surgery was about 7 months ago and my diagnosis was last February. And anyway, and I was put through some chemo as well and the estrogen treatment, etc.
Right.
It's been a bit of a tough road not knowing which direction one's really going and whether things are improving or whether you are normal in your process. The one question I'm going to ask, and I hope I'm not going to be standing on toes, and I know I am, but I'm going to ask this question. Will the urologist, can we ask for an honest answer on how much sparing did occur? Because first of all, I will be honest, I have very difficult to get meetings with the urologist. When you do, there's a clipboard in front of him, he's got his agenda, he talks to you, he doesn't listen, and he says, yes, okay, that's fine, no, you just keep on doing what you're doing, that's good. And he talked about injection. Christine did talk about injection, and I wish I had understood a lot more about that. The natural squeamishness, which we were talking about earlier, is, I think for men, it is a major thing.
Yes.
Well, I know for me it was. Yeah. And I kind of said, yeah, but let's do the pump. I've been doing the pump. Now, I don't want to go through my entire history, and I know I'm taking up time here, but I would like to say, can one demand to know whether one has lost all nerves, all the woman nerves in that?
So, you might want to speak to this too, but that, when you're in surgery, robotic or open,
this was open.
You can do your best to try to preserve it. And you can actually pull the nerves apart, take the prostate out. Okay? But there's accessory vessels that you can hit that cause some bleeding. It always bleeds, right? And you don't know, even traction on the nerves can cause that. So in their report, they can tell you whether they think they've spared the nerves or not. They're usually pretty honest when they've had to take out a nerve. On one side, for example, the tumor's on that side, they have to do a bigger scoop. They want you to live, so they take a bigger scoop. and they'll say we lost the nerves on that side or we lost them on both sides. They're usually pretty honest. So I don't think surgeons sort of lie and say I spared the nerves when they didn't, okay? But they're human. But even if they did very, very careful nerve sparing, they could still have damaged the nerves. So all you're going to get on the report is nerve sparing, unilateral or bilateral loss. Do you want to add to that?
Yeah, no, I totally agree with that. I mean, the surgeon isn't trying to hide anything from you, but one of the places where you can get an idea is from the operative report. So the surgeon will describe what he or she tried to do or did in the procedure, and usually they'll say, you know, the cancer was more on the right, for example, so we did a wide excision. We believe, you know, we did a partial nerve sparing on the left. But, you know, the point is, to your real question is, even if the surgeon could tell you, honestly, you know, and I'm not saying they're not honest, I don't mean to say that, but I mean, if there was a definite way for them to say, oh yes, we have 35% of the nerves preserved, which they can't do, it doesn't necessarily mean that the function of those nerves is going to be what you want. And that's really what you want to know. And unfortunately, the only way you can tell that is by all these different ways of trying to get the function back.
So that's why the cavern map, where they say, oh, we saved both nerves,
Yeah.
but in the end,
it was no
the,
good.
the function doesn't, it's not, nerve sparing does not equate to perfect function.
You know, I just wanted to say it was nothing to do with the honesty of the
Right,
the-
right.
That the reticence to discuss was
Well,
Yeah.
the
see,
real
to
issue.
to me, that's a whole different problem
Yeah.
that you're bringing up. That's one of the reasons why we even have this program, because sometimes it's a matter of time, because, you know, some of these people are trying to see 30 people in a day, and for them to get involved in these conversations doesn't always fit in that kind of a day. And this is true whether it's Canada, whether it's the U.S., and that's why this kind of program is so important, hopefully, to impart that kind of education to patients that need to understand these
Anyway,
things.
thanks for this education.
Thank you. Last question here? Yeah.
I would like to ask you a question about hormone therapy. I understand from what you said, it seems to me that there would be less possibility of nerve damage if there's been no surgery after just taking hormones.
So the question is, what about hormone therapy? If you've never had any surgery at all or any radiation at all, then the nerves are what they were. Right?
Radiation would hurt.
Radiation would hurt the nerves, but slowly. Okay? But then when you drop the hormones down to zero, the testosterone down, then the sexual function suffers. It's harder to get an erection. It's harder, your libido's down, and it's harder to reach orgasm, even though the nerves haven't been cut. Right? So hormones do make a difference. Yeah.
How soon will Cialis be available as generic? Offshore meds.
Generic Cialis will be coming probably this year.
This year.
I think so. I'm not sure.
The offshore Cialis.
Don't forget, generics are not that much cheaper. The offshore stuff that you get is usually on the internet, and you don't know what's in it. That's the biggest scary thing, is that PD5 inhibitors are very popular, so there's a lot of junk, including paint and rat excrement and stuff in those pills. So I'd just be very, very cautious. So I think we'll wind up, and if anybody'd like to come down here and talk, and thank you so much for coming.